Welcome to the IAPB Learn IAPB Standard Guidelines for School Eye Health Programmes webinar. My name is Susan Evans and I'm the Seeing is Believing Project Officer IAPB. I'm also a member of the IAPB School Eye Health Working Group and I will be chairing this webinar today. This is the first in a series of IAPB Learn webinars that my IAPB colleague Emma Footy has arranged to encourage our IAPB members to connect and learn on a range of eye health areas. Earlier this year, the IAPB School Eye Health Working Group developed a set of guidelines for school eye health programmes, and today members of the group would like to share some of the key elements with you. Thank you all for attending today. We really appreciate you taking the time to join us and be part of our learning community. A big thank you to our webinar presenters, Dr. Priya Mojaria, Research Fellow, the International Centre for Eye Health, Professor Claire Gilbert, Co-Director, the International Centre for Eye Health, Hassan Minto, Director of Child Eye Health and Low Vision Programmes, Brian Holden Vision Institute, and Global Programmes Director, Our Children's Vision, and Samrana Yasmin, Regional Director, Southeast Asia and Middle East, Brian Holden Vision Institute. So the agenda for the webinar today will be welcome and housekeeping notices by myself, introduction to the IAPB Standard Guidelines for School Eye Health Programmes, Dr. Priya Mojaria, Epidemiology of Eye Diseases in Children and Teachers and Monitoring School Eye Health Programmes, Professor Claire Gilbert, overview of the key components of a comprehensive school eye health programme, Hassan Minto, and after the presentations, I will chair a question and answer session. I'm now pleased to introduce Dr. Priya Mojaria, Research Fellow, the International Centre for Eye Health, to give an introduction to the IAPB Standard Guidelines for School Eye Health Programmes. So Priya, over to you.
Thank you very much, everyone, for joining us this morning. I want to give a bit of an introduction on the guidelines and how they came about and what the purpose is for these guidelines. So the opportunity came about to write these guidelines because we began to see that the school eye health programs are a unique opportunity to provide comprehensive eye health services to potentially more than 700 million children throughout the world. The guidelines were developed to provide direction to individuals and organizations who plan and implement school eye health initiatives, and to provide a way of doing this in a standardized methodology so that results could be compared, but also everyone could adhere to certain global standards. The guidelines were supported by the World Bank and the Global Partnerships for Education, and they were initially developed jointly by members from Brian Holden Vision Institute, Sight Savers International, and the London School of Hygiene and Tropical Medicine. We initially developed these guidelines as global standards, but in further iterations, we realized that these needed to be revised specifically for low and middle income countries. We had feedback from the School Eye Health Working Group at the International Agency for the Prevention of Blindness and leading experts and international NGOs involved in school eye health. In 2017, the initial guidelines were reviewed and we updated these based on feedback from the working group. They were then published and disseminated by the IAPB in Feb this year in 2018. The guidelines have been translated into Chinese, French, and Spanish, and these are undergoing proofreading to ensure technical translations are correct, and they will be available for download from the IAPB website from next week. They're currently also being translated into Russian and Portuguese, and we advocate for the use of these guidelines in programs and welcome all feedback. All the feedback will be collated by the School Eye Health Working Group, and we then aim to make this a live document and improve based on the feedback that we receive. Thank you.
Thank you, Priya, for giving us that overview and sort of introduction to the School Eye Health Guidelines, really. And I know a lot of people have put an awful lot of work into them, so it's great to have this opportunity today to share with you some of the sort of the key elements of it, really. So now let me introduce Professor Claire Gilbert, the co-director of the International Centre for Eye Health. And Claire's also going to show her screen.
Thank you very much, Susan, and welcome everybody. I'm going to talk about the epidemiology of eye diseases in children and teachers, and just give a very brief overview of the purpose of monitoring school eye health programs and what data might be collected and why. You may wonder why I'm talking about this topic, and that's because we want school eye health to be as comprehensive as possible and not just narrowly focus on diagnosing or detecting and correcting refractive error, because this really is a missed opportunity for addressing a lot of other eye conditions in children and also in the community. So I'm going to cover the following conditions very briefly: myopia, vitamin A deficiency, trachoma, and a few other common and less common eye conditions in children, and the implications these have for school eye health. I'm also going to briefly cover the eye diseases that may affect adults, so in other words, teachers, and monitoring school eye health programs. So briefly, epidemiology is the study of diseases in populations, and epidemiology asks 4 questions. So how common is the condition in the population? There are 2 measures. One is the prevalence, and that's the proportion of the population who are affected now. Incidence measures the rate at which new cases develop and is much more difficult to measure. It also asks who is most affected by the condition, by age, gender, ethnicity, and so on. What are the underlying causes, and importantly, what can be done or to prevent or treat the condition? So first of all, I'm going to start talking about refractive myopia, which is the commonest refractive error in children. You will see in this graph, which is a review of over 140 studies, where the data have been analysed by region and by age group. And what you can see is, first of all, there's very wide variation in the prevalence in different populations, with Black children in Africa and Hispanic children and Latinos having the lowest overall prevalence, and East Asia having the highest. And another thing which I'm sure you're all aware of, that myopia usually starts around the age of 10 and then can progress. And in East Asia, this is really becoming extremely marked, with a very high proportion of older children having myopia. This is important for 2 reasons. One is deciding whether it's really worth doing a program to detect refractive error if the prevalence is really, really very low. And secondly, to help to guide which age group should be included. In East Asia, primary school children would need to be included, but probably not in other regions. This slide here shows the difference in prevalence between urban and rural children, and you'll see that in many regions the prevalence is higher in urban areas than in rural areas, and again, one needs to bear this in mind when planning services. So why does urban living increase the risk of myopia? There are 2 possible mechanisms associated with increasing urbanization and increasing educational pressure. And of these 2, lack of time outdoors is thought to be more important than prolonged periods of close work. And there are some studies going on at the moment to try and increase the amount of time children spend in daylight, either by encouraging them to play outside or do sports outside, and or creating classrooms which are let in more daylight, as you can see here. And there is some evidence that this is now reducing the incidence or the new cases of myopia, which is very good news. And also, spending out time playing is generally good for children. It's good for their well-being, social development, and so on. So other eye diseases in school children and diseases which may be locally endemic also need to be thought about. So children can have a whole range of common but not severe eye diseases, such as conjunctivitis or mild allergies or lid infections. But particularly in resource poor settings, they may have other conditions which have not yet been detected and treated, including severe allergic conjunctivitis, strabismus, even undiagnosed cataract, corneal scarring, and other causes of visual impairment. So it's very important that systems are put in place to detect and treat common eye conditions, which can be done by training a school health team, or it can be done by the team themselves. It's much better to train school nurses or a teacher, because they are going to be there after the program leaves. Again, there must be a systematic approach to detecting and referring more serious conditions with clear referral criteria and systems and mechanisms to monitor whether children actually attend and receive the services that they need. Vitamin A deficiency is a public health problem despite global efforts for control, particularly in sub-Saharan Africa and countries in Asia. Many of you will know that this is an important cause of blindness, but also increases child mortality by up to a quarter. So this is why there are the global initiatives for control. And in many low and middle income countries, nearly a third of preschool age children can be vitamin A deficient. Active trachoma, I expect many of you are aware of the global initiatives to control trachoma, and there's been intensive efforts to map where active trachoma is, and you can see from this map where the main foci of infection are in sub-Saharan Africa and in Asia. So what can we do about this? Lots of things. I would suggest we can include it I would suggest it's included in health education of school children, and be advocates for better water, sanitation, hand washing, and home gardening, with separate latrines for boys and girls. They obviously need to be kept hygienic. And also we can be an advocate for vitamin A rich foods in school meals. I went online, and most of the photographs I could see of school meals were basically carbohydrate, a bit of milk here, and very, very low vitamin A looking food. This was the only photograph I could find where there's yellow and orange fruit and vegetables, which have got vitamin A in it. So this is sending all the wrong message to the future parents about what a healthy meal is. So what can we do about controlling these locally endemic eye conditions in school eye health? We can educate the next generation of parents on how to prevent vitamin A deficiency and to control trachoma through all these different things here, which I've already mentioned. We can also use the child-to-child approach, which is when children are become little advocates and messengers to take health messages home, and this has been found to be quite effective. We mustn't forget teachers. They are a very valued and valuable resource in low-income settings. It's often difficult to attract teachers to rural areas, and they need to be able to function to the best of their ability. We know that presbyopia is common in adults aged over 40, and many teachers are presbyopic or have mild presbyopia, and these teachers need to be detected and treated. This will also act to show them the benefits of spectacle correction. Glaucoma affects 3 to 5% of adults aged over 40 years, and in every country, 60, 70, even 90% are not diagnosed. And so the team can examine the optic disc of teachers, ask if there's a family history, and refer relevant teachers for assessment. Again, diabetes is becoming increasingly important and can affect 10 or 20% of adults in urban areas, particularly in Asia. They need to be referred for a retinal examination and the importance of it highlighted. So what's the relevance of epidemiological data for school eye health? It helps us to inform decisions. If you don't have data for your country, then you may find the maps that I've included quite useful. You could do a quick review of the literature. And if myopia is a public health problem, you need to consider what age vision screening should start, and also how frequently the screening needs to be repeated. And Hassan will mention some of these aspects. Let's move on now to monitoring and evaluation of school eye health programs. We're all aware of the planning process, but we often tend to start with what we want to do. We measure how much we've done, and we often forget about the outcomes and the impact. So when planning, you should start with the positive change that you want to see. So you start with the impact and the positive outcomes, and then you work back to see what objectives would need to be fulfilled for you to be able to achieve your goal or your aim. Now, monitoring is a way of assessing whether all these activities are taking place, and evaluation is a way of assessing whether there has been any positive change. Both are often done poorly or inadequately, particularly evaluation. So how is monitoring defined? It's a systemic and routine collection of information. This needs to be thought about and planned at the beginning. And the whole purpose of monitoring is, if you look at the bottom slide, is to monitor and check progress against objectives and plans in order to find problems so that corrective action can be taken. So you don't come to the end of the program and suddenly realize, oh dear, I wish we'd known this earlier. So it's a way of really just looking at what's going on, finding problems, and then taking action to try and correct them. Evaluation is a bit different in that it allows us to have a bit of a bird's eye view of what's been going on, and the purpose of it is to see whether the program has achieved the desired goal and the process entailed in reaching the goal. This can be done in a big program halfway through. It's very useful to get external experts to do this because they have fresh eyes and may see things that people delivering the program may not have seen. And also at the end of the program to see what positive change all that investment and time and money and effort has actually made to children and their vision and quality of life. This is a useful flow diagram, and it's a useful way of seeing where the different monitoring indicators fit in. So we start with the number of children enrolled in the school of the relevant age, and then not all of them are going to be available. It's useful to monitor that. Not all of those available will have their vision screened. We need to monitor how many passed screening, how many failed screening, and how many could not be tested. And then amongst those who failed screening, a critically important indicator is how many passed on retesting, because this tells you about the quality of the screening. And of those who were confirmed as having poor vision, how many of them were actually refracted, how many spectacles were prescribed, how many got their spectacles, and how many are wearing them. We often don't bother with this last bit. And last of all, these big boxes are for evaluation. What was the benefit? So here you see that the top data collected from the top boxes allows you to assess the coverage of the program. Collecting data on these allows you to assess the quality of the screening, and then these are uptake of refraction, need for spectacles, whether they actually got spectacles and wear them, and whether they benefit. And you can do the same for the other eye diseases which are referred during the process, whether the children attended and whether they had the treatment that they needed. So here's just an example. Imagine we've got a dozen schools, or how many schools, in which there are 10,000 children, and 4% have a significant refractive error. So that means in this population of children, there are 400 who need spectacles. As a result of monitoring, we find out that 8,000 children were screened, that's 80% of the total. 4% failed screening, that's 320. But only 60% of those children attended for refraction, which is 192. Only 60% received their spectacles, that's 115. And then when the team went back at 4 months to see whether the children were wearing their spectacles, it was only 30%. And I have to say that this figure of 30% is not uncommon. So if we multiply these all up, we find that only 35 of the 400 children who needed glasses were actually wearing them. That is less than 10%. If we don't have this data, we don't know what we've done, what we've not done. And if we do collect this data, then we can dig into why did so few children come for refraction? what can we do about it, and so on. So it allows us to identify problems and take corrective action. So this is just some ideas of indicators that could be used. These indicators are just data that you collect on a routine fashion throughout a program, and there are more details in the guidelines. Teachers' eye health, again, we need to know the proportion of teachers who are prescribed presbyopic correction, who are referred, who are diabetic, and who may have signs of glaucoma. So in evaluation, we want to know what difference has the program made to children and teachers in terms of maybe quality of life, visual function, and academic performance, although the latter is very difficult to do. And have there been any negative consequences? Are children being bullied or ostracized or teased? Evaluation is incredibly important, and measuring these outcomes is difficult to do, but I really put it out as a challenge. We need much more data on the benefit overall of school eye health programs. So in summary, uncorrected refractive errors are the commonest cause of visual impairment in children, but we must not forget the other eye conditions, which may be common, they may be more serious, which children and teachers may have, as well as the endemic conditions in the preschool age population, and a range of different strategies are required. Some of the interventions to be, like health education, to be sustainable, needs to be included in the curriculum for teachers and children and in health policies as relevant, and monitoring and evaluation must be thought about, planned and budgeted for at the outset. Thank you.
Thank you, Claire. That was a really interesting presentation, and some of the key elements of, the importance of collecting data, some of the emerging eye conditions such as myopia, not forgetting the other eye conditions, so not making it all just about spectacles, but also the other eye conditions that children have in schools, for example, conjunctivitis. Really good to kind of raise those issues. And again, the systematic approach, thinking about how you can strengthen the system that's already there rather than setting up parallel systems, and the importance of monitoring. I mean, it's quite a shocking statistic that only 35 of 400 children who needed spectacles were wearing spectacles. So, just that importance of monitoring and looking where those gaps are and where we need to kind of input. So thank you so much, Claire. That was a really interesting presentation. Let me introduce Hassan Minto, the Director of Child Eye Health and Low Vision Programmes, Brian Holden Vision Institute, and Global Programmes Director, Our Children's Vision. So Hassan, over to you.
Thank you so much. First of all, let me thank IAPB for creating this opportunity for the dissemination of these guidelines. And I'll start by adding to what Priya just introduced these guidelines and why we needed these school eye health guidelines, and why is it important that we focus on eye health in children. We know that we need a consolidated global effort for our children because children who have vision problems are 3 times more likely to fail at least one grade level. We know that 80% of what children learn is processed through the visual system. 90% of the world's vision impaired are located in developing countries where services are limited. 80% of vision impairment is preventable or curable. 63%, and this 63% is a slightly older data. We could not get age segregated data, and I think that number is higher than 63%, but we do not have the published evidence for that. In 5 to 15 years of age is due to uncorrected refractive errors. And as Claire said, myopia is the leading cause of refractive errors. But most alarmingly, these numbers, right now we have 195 million people globally who have refractive errors, but this number is going to rise to over 4.76 billion people by 2050 if we don't do anything. And that is why it has now become a matter of urgency that we implement a standardized school eye health program globally. Now, reaching children is more critical than ever. We know that by 2050, it is estimated that half of the world's population will be myopic. That is, 1 billion people will be highly myopic and at risk of developing blinding conditions. High myopia can be prevented with early correct interventions, but only if provided while the eye is still developing, typically up to the age of 12 or 13, and that again emphasizes the need for a good quality school eye health program. Providing children with vision care and lifestyle interventions is critical if we are to prevent a public health crisis. Consider having a billion people who have problems with their eyes which can't be treated with spectacles, and the workload that is going to create, and the number of people who will be blind or vision impaired because of myopia or high myopia. Millions of children in developed and developing countries are vision impaired because they do not have access to services. Claire, in her presentation, mentioned Africa and the low prevalence of reflective errors in Africa. However, we must also consider that although the prevalence of reflective errors in Africa is quite low, also the practitioners and services in Africa are similarly low. And that is why when we do provide services in Africa, we find much more children with uncorrected refractive errors than in other parts of the world. And the reasons are fairly simple. There's a lack of skilled practitioners, particularly those who can prescribe for children. There's inadequate supply of good quality spectacles. There are not enough facilities where people can go and get their eyes checked, or especially where the children can get their eyes checked and get their spectacles. And that is why millions of children around the world are unnecessarily blind or vision impaired. Now, going into how we start a school eye health program is very important. Eye health programs should be an integral part of a broader school health program where possible. And where a school health program does not exist, a school eye health program could be a precursor to starting a broader school health program. So it could be either way. Initial engagement with the government, especially with the ministries of health and education, is critical to ensure that programs are actively owned by the government to make it more sustainable. We have seen NGOs and other groups go in, do a fantastic program for 3, 4, 5 years, provide a good coverage, and then when the funding ends, the program vanishes and there's nothing much left on the ground. So unless the programs are embedded within the systems, I think we would not get the desired results. We need to see that the donor organizations, corporates, private practitioners are involved in are appropriately involved in supporting the programs from the beginning. So it's a partnership of owned by the government, but supported by all the concerned parties. What is very important, and it's also highlighted in the school eye health programs, are some of the key asks for promoting eye health programs. And these could be that the governments should actively own the program by ensuring that skilled human resources are available to provide services. Even where there are optometrists available, it's not part of their job descriptions to go out in the schools and do the screening. Or where there are teachers, it's not part of their job description to provide screening for children. So we need to see that, and unless we take the governments on board and see that there is relevant systems in place, these people are not available, are not willing to do and go out and provide the services. That there's necessary equipment and infrastructure is available. There's an adequate budget line are allocated for implementing of school eye health programs within the ministries of health and education. There's an ongoing free supply of spectacles for children who can't afford spectacles otherwise. There needs to be a clear referral mechanism. It needs to be established where children who can't benefit from spectacles or other simple interventions are referred for a tertiary level care, and particularly children with vision impairment or low vision or blindness for rehabilitation. Eye examination should be part of admission procedures in primary education. A child while entering primary education should have their eyes tested. School curriculums should include outdoor activities for children for at least 2 hours every day. Child eye health directly contributes to the attainment of sustainable development goals related to health, education, quality of education, poverty and well-being, and economic growth. So these are some of the key asks, and when we are developing the program and we want to pitch these programs to the government, I think these are things we need to consider. What are some of the components of a comprehensive child eye health program? An ideal school health program for children should encompass the following and be integral into and should be integrated into a school health program. Identification of children with significant refractive errors with provision of high quality spectacles that look good and which are comfortable, durable and affordable. Health education or other activities to prevent locally endemic diseases, e.g. face washing and the importance of clean environment at home to prevent trachoma. I think Claire has emphasized that enough. Provision of presbyopia, age-related near vision disease, correction for teachers who require them, promoting healthy school environment, growing vitamin A-rich foods in the school, gardens, bottle collection for face washing, identification and referral of common complaints of children like styes, conjunctivitis, using the child-to-child approach to take eye health messages home and use children as case detectors of individuals in their families and communities who need eye services. Now, the guidelines focus on steps in planning for school eye health program, and I think you'll need to go through the guidelines to. It's just a very brief synopsis of what is in the guideline. It tells you how a program should be implemented, what training needs are there for the human resources required for a school health program. The guidelines also provide you with the technology guideline of what equipment you need for various levels. Claire has already in detail mentioned about the monitoring and evaluation framework for the effectiveness of the program. And lastly, we need to have embedded child protection and code of conduct of working with children in any school health program that we develop. Now, detecting and management of refractive errors and other conditions in children. When we look at children to detect ocular morbidity early, we would like every child who enters primary education system, ideally between the ages of 5 to 6, to receive a screening, and any child found with an eye problem should be treated or referred. To detect refractive errors and ocular morbidity, our target group is between the ages of 11 to 18, where refractive errors are now becoming much more significant and myopia is manifesting. We recommend that we do not use the standard methodology for vision screening, which many programs use, which is using a Snellen chart at a distance of 6 meters. Rather, use just one row of optotypes calibrated for 6/9 at 3 meters, and they have crowding and aspect ratio, and they follow the logarithmic principles because we want to know whether the child can see 3 out of 5 optotypes with each eye and binocularly for pass and fail. Anything more than that is useless and will be repeated again in the clinic and will increase the time that we spend on the child and also reduces the accuracy of the program. Screening for ocular morbidity, we ask about eye and vision symptoms before vision screening. Eye health and vision screening of all children needs to be undertaken by trained teachers, community health workers, eye health workers or school nurses. And just for your information, there are standard training manuals for these workers available, and we hopefully will be able to share these soon on the IAPB website. Eye examination by optometrists of all whose visual acuity does not improve to normal with refraction in one or both eyes. Referral of all those whose acuities do not improve to normal with refraction in one or both eyes or have other conditions that require tertiary care. Now coming to the prescribing guidelines, prescribing should be based not on the visual acuity but improvement in distance vision acuity with refraction and not the degree of refractive error. Myopia or minus lenses improve vision by 2 or more lines. Hypermetropia plus lenses improve vision by 2 or more logmar vision lines and or noticeably improve comfort. Astigmatism cylindrical lenses improve vision by 2 or more logmar lines and or noticeably improve comfort. Anisometropia is significant. Anisometropia plus correctly balanced lenses improve vision of the most affected eye by 2 or more logmar lines and or noticeably improve comfort. The degree of improvement in VA should be tested uncorrected, with corrected lenses, and with both eyes open, that is binocularly. The one thing which many programs struggle is the lag time between providing, taking the prescription and then providing spectacles, and ready-made spectacles offer some of the solutions to those problems. And children, however, children need to fulfill all the following criteria to be eligible for conventional ready-made spectacles. According to the prescription, spherical equivalent improves the vision equal to or not more than one line less than full correction in the better eye, and difference between the spherical equivalent in each eye is not more than 1 diopter. The spherical equivalent is between minus 3.5 diopters and plus 3.5 diopters. According to the frame sizes, now the frame must fit the face of the child correctly, and they should like the frame, and it should be cosmetically presentable and should not make child a victim of ridicule or other problems. And the interpupillary distances match that of the frames available, and not more than 0.5 prism diopters of induced prism is there. The spectacle frames are acceptable to children, and the spectacle frames are a comfortable fit. In terms of when we are designing a program and we want to know what population we want to cover, we need to look at the overall population in an area. We need to look at how dense that population is, or how widely spread that population is. For example, when we look at East Asia, we know that we have large concentrations of populations in small areas. When we go into Africa, we have much less dense population, and if we want to cover, say, 10,000 kids, in China, we need to only look at an area of a few kilometers. In Africa, we might have to go into a radius of about 15-20 kilometers. We must look at primary school enrollment by gender, and what is the percentage of children enrolled in primary school. If in a country the primary enrollment is low, then and say 30-40% children are not in primary school, then we need to consider mechanisms on how to reach children who are not enrolled in school. And we also know that the enrollment is also affected by gender. Less girls are enrolled in primary schools considered to boys. We need to consider the secondary school enrollment again by gender. We know lots of children drop out after completing their primary school, and if that's the case, we look at the school dropout rates, and our second entry point into the school health programs is the final year of the primary schools rather than the first year of the secondary schools, because number of children have already left. So those factors need to be carefully considered. Frequency of vision screening, as myopia usually starts during late primary school age and in some conditions progresses over time. Schools should be visited every 1 to 2 years so that we can follow up on children whose myopia who have been diagnosed earlier with myopia, and those who are newly enrolled. The personnel that you need for a school eye health program include a contact teacher that helps screening, record of those screened and those referred, send lists of children referred to a referral center, follows up those who have or have not gone for treatment. Then we have people who actually undertake the screening, and these could be teachers, nurses, community-based workers, eye health professionals. They screen all listed children and record findings as per the standard operating procedures. Ensure children who fail screening are referred for refraction or for treatment of other eye conditions. Prepare a list of children who fail screening for contact teachers and refractionists/optometrists. Collect and deliver spectacles to schools. The third and very critical part of this program are the optometrists who refract and prescribe according to the standard operating procedure, record prescription. If vision does not improve with refraction, record a preliminary diagnosis and refer according to the standard operating procedures to the next level, which could be either a secondary or a tertiary level. Give contact teacher list of children who fail screening and require children or are referred. Give list of children who require spectacles to the relevant dispensing optician, and the role of dispensing opticians who make spectacles correctly using the correct frame, and mark each pair of spectacles with the child's name, class, and school. Now, code of conduct of working with children includes, and this is very important, and sometimes this is overlooked and people take it lightly. But whenever we design a school eye health program, it is critical that we ensure that child protection is embedded in the program. We need to treat all children, young and young people with respect, regardless of race, color, gender, language, religion, political or other opinions, national, ethnic, or social origins, property, disability, birth, or other status. Encourage an open communication. Listen to the children, their problems, and see if we can address those. Immediately report any concerns or allegations of child abuse or child exploitation. Only record an image of a child with the consent of the child and his/her carer, and only after explaining to them the purpose. We do not engage in behavior that is intended to harass, shame, humiliate, belittle, or degrade children. We do not use inappropriate, offensive, abusive, or discriminatory language. We do not smack, hit, or physically assault a child. These are some of the references, and our logo is vision for every child everywhere. Thank you very much.
Thank you, Hassan. That was a fantastic presentation. You managed to do a really good synopsis of the guidelines. I think the guidelines are about 70 to 100 pages, and I appreciate you managed to really kind of summarize them very well. And also great that you emphasized the point around, linking in school eye health programs should be linked in with a school health program. So working with the Ministry of Health, working with the Ministry of Education. So that was really useful. So thank you so much.
You're most welcome.
Thank you. And I'm blown away really by the wealth of knowledge we have with our presenters today. And now the opportunity goes over to our attendees, who now can ask questions to our presenters on any elements of the presentations they've done today. And we already have a question in. We probably got about 15 minutes for for questions and answers. So if you do have a question, please do get it in quickly, so your question is able to be answered. We already have a question already, so I'm going to start with that one. And in the meantime, attendees, please do type your questions in the chat box, and I'll present them to the presenters. So our first question is for all of our presenters, and is from Ashok Rana. And they've said, we have done re-screening of the students to whom we have given spectacles 2 years back. After re-screening, the results were that 50% of the students were not wearing spectacles due to various reasons, for example, lost glasses, broken, etc. What strategies can be used so we make sure children wear the spectacles? And they've added the frames were they were good quality frames, so they were nice frames. So I think if we do the answers in the same order of our presentation, so if we start with Priya, then Claire, then Hassan, and then Samrana, if you want to chip in as well. So we'll start with that question, and that will give the attendees time to ask additional questions. So Priya, do you want to give your thoughts on that question? What strategies can be used to make sure children wear the spectacles?
Thank you. Firstly, just to say to Ashok that 50% is actually a higher wearing rate than in a lot of studies that we've seen. So congratulations on that. And also well done on the initiative to go back after 2 years to re-screen and follow up on those children. Some of the ideas that can be, some of the strategies that you can adopt are by giving teachers a spare pair to keep. There has been some evidence around if a teacher keeps a spare pair in the classroom, that children are more likely to then ask for that pair when they're broken or lost, and teachers can also monitor that. One of the things that I did in some of the research that I was doing was involve the teachers and the children in the classroom and parents to make sure they understand why the students, their peers, or the children are wearing those glasses and why they need to wear them. And if the importance of that is recognized quite early on, you might find that they also help and encourage the children to wear them.
Thanks, Priya. Claire, what are your thoughts on this?
I don't think I really have anything further to add. I think what Priya recommends is very good.
Thanks, Claire. Hassan?
Yes, I think I would like to add to what Priya said. We need to, first of all, again, I agree with Priya. 50% is a fantastic rate after 2 years, but the rates that we find are much lower. Uh, we have undertaken 3 major studies in Nigeria, Malawi, and Pakistan, where we have gone in and looked at children after 3 months on the number of children who are wearing spectacles, and we have looked at causes of why children wear glasses and why children don't wear glasses. And there are a number of findings that we have, and we are hoping that we will soon publish those papers. The key finding is that many children don't like to wear glasses. Many children have their glasses broken and their parents refuse to buy them a new pair. Gender is a very big issue where girls are less likely to continue with the glasses because their parents think that has an impact on their marriageability, or I don't know what's the right word for that. Often a problem that we find is that the prescription that was originally given was not correct, or the power was so small that it did not make a big difference to the vision of the child, and the child did not perceive any big value in wearing those spectacles. So we need to follow the prescribing guidelines and see that our prescriptions are correct. We need to see that our ideally, and there's a paper that we have just completed as School IS working group, which emphasizes the importance of undertaking a cycloplegic refraction on all children and to see that the refractions are correct and the children are comfortable with their glasses. And then I think we cannot undermine the role of health promotion and getting the parents and teachers on board so that if a child doesn't wear glasses, they find out why the child is not wearing glasses, and if a child breaks glasses, the parents are motivated to buy glasses for that child. There's a lot more, but I think I'll leave my answer to that.
Thank you. And Samrana, anything to add there?
Hassan covered most of the stuff, so thank you very much for that. Just want to use one additional thing which we found really useful when we were doing some of the work around school eye health or school health programs. Compliance is directly related to behavior change, and we believe that positive reinforcement is critical. So having a very strong component of health education and health promotion embedded in the program can lead to better compliance. And we need to see that what strategies then we can use according to our own local context to make a good use of it. So orientation session at the start of any screening program showed significant value for us in certain programs, so that can be considered as well. Thank you.
Excellent, thank you, Samrana. And actually that leads quite nicely on to, we've got a couple of follow-on questions around health education. We've got one from Raul Sousa from Portugal, who's asking about do the guidelines cover health education and about healthy visual habits and health literacy, like eye health literacy. So something around with the health education, who should do it, what should it contain? And then also from Joseph Nong Kenji, who's asking any ideas about how to overcome myths and encourage children to wear glasses, that wearing glasses can be a sign of disrespect in some cultures. So sort of how can health education overcome some of these myths, and how should we be, what should we be thinking about when we're doing health education? So again, if we go through the same order, if we start with Priya, Claire, Hassan, and then Samrana.
Hello. So I think Hassan would be better placed to answer this in detail, but I would give a brief thoughts on this. And in terms of health education, it's really important that the people that make the decision about why a child wears or does not wear their glasses are involved. And some of my research that I did was about involving parents into this decision-making process. But as Samrana very rightly put, behavior change is very complex, and who does it, when it's done, it has to be very culturally and context specific. And that was one of my key findings from the work that I did, that it's not enough to do generic health education in a classroom, and it's important to involve people at all levels. So in a lot of cases, sometimes it's not even the parents who are making the decision about why a child wears or does not wear their glasses, and there's so many different levels of how to do behavior change. One of the complexities being, again, what Hassan said, that something is the whole notion that if a girl is wearing glasses, she is less marriageable, is a very culturally embedded belief, and so it takes a while to change that sort of behavior. So I would let the other speakers elaborate on that.
Thank you. Claire here. I'm just going to answer slightly more broadly in terms of a broader health education about how children can keep their eyes healthy. Ideally, this needs to be embedded in whatever health education children are having about other conditions. And I think many schools do have whatever they call it, human biology or whatever. So I think the first thing to do would be to find out, do the schools have this health education? Who delivers it? And what topics does it cover? And does it cover eyes? How to prevent, in Portugal, I would think probably how to prevent infection by hand washing and keeping their faces clean, and particularly injuries, how they can prevent injuries during sport or during firework displays, and wearing seatbelts and all that kind of thing. So to see how messages about keeping eyes healthy, injury prevention, can be included in a broader school health teaching. Hassan?
Yes, Claire, I totally agree with what Priya and you said. I'll just add, I think from my perspective, health promotion is perhaps the most important part of a school eye health program. And if we do everything else and we don't do health promotion, and we do not send the right health messages, and we do not enforce those messages to the right audiences, a school eye health program is pretty useless. And I'm making a strong statement here. Because then, as you have in your monitoring thing pointed out of the 400 kids that needed spectacles, only 35 wear them, and that's a very poor outcome, and we do not want that. That can only be changed if we have systems in place, if we have if we encourage, or if we have the right messages for the right audiences and embed them within the curriculum, in the schools, within the curriculum for the teachers, within the curriculum for the eye health professionals who go out in the schools. The school eye health guidelines talk a lot about health promotion, and particularly the importance of health promotion in terms of myopia control. You have already covered the face washing and the other stuff. And 2 hours outdoors is now becoming a critical issue if we want to deal with the epidemic of myopia. The role of parent teachers associations cannot be underestimated. And any screening session in a school should start with a session on health promotion for all children, and it should be made interesting. It should be something that is not something that the children think is just another activity. And last point that I would like to make on this is that we are developing a tool which is near completion. We have developed it with support from Euclid, and it's being translated in English right now, and hopefully it will be translated, and it will be something that we want any school, whenever there's somebody undertaking a screening program, start with that cartoon, that pictorial thing which sends the right messages, and also the messages that go to parents and go to teachers and other key stakeholders. We lastly need to see that we constantly reinforce our messaging, particularly around girls, and see how we can fight the taboos against that work against girls wearing or using spectacles. I think I'll leave it at that.
Thanks, Hassan. Samrana, over to you.
Hassan covered quite comprehensively. I just have two additional things which might help our participant to be more creative around health education. One thing which has helped us immensely was when we engaged communities and parent-teacher associations while developing our key health messages for certain communities. Because when they are part of the process, that message automatically gets built in, and they have a direct association and an ownership of that message. And then it's much easier for the communities to take that forward once even the program is completed. And the second thing which we also need to consider is that how these messages can be used more broadly, especially in context of out-of-school children or children who are in more informal education systems. So the role of social media, we know every kid is on one thing or another when it comes to social media. So we need to see that how we can embed some of those elements within our programs to use these technologies and appliances. Thanks.
I would just like to add one point, Samrana, if I may.
Please go ahead.
We should all consider the child-to-child approach, and I think Claire briefly mentioned that in her presentation. We did a research in Tanzania where we trained children and they carried these messages, and we made these children, we called them vision champions, and they were then responsible for compliance, also for testing, taking the messages to parents and all of that, and that tremendously improved the compliance and also the referral of children, because when children are referred from a screening program, the very small percentage of children who actually present. But when we introduced the vision champion, that percentage went up by 10 times of children who were presenting at the vision centers voluntarily for their eye checkup. So child-to-child approach or vision champions, and we have developed a cartoon book around that, which we gave to the children, which has 6 basic messages, and that was a tremendous help. So don't giving ownership to children for their own things is I think a very important thing in health promotion.
Absolutely.
Thanks, Hassan. Yeah, no, really important. Okay, so I can see we do have a few more questions, but I'm quite mindful of the time. So what I might do is if people have got if you've written a question and we haven't had time to answer it, if the presenters agree, what I'll do is I'll forward your question to the presenters and then they can get back to you directly over email. And additionally, if you do have any further questions that you want to ask, you can just email us and we'll forward them to the presenters to you, and then you can have that sort of interchange over email, because I'm aware that I know time is precious and we've already had a couple of people dropping off now. So I think what we'll do, we'll end the question and answer session here, but I'm just going to hand over to Samrana, who's going to do a sort of a summary of the presentation, a summary of the presentations today. So Samrana, over to you.
Thanks, Susan. First, I would like to thank Claire, Hassan, and Priya for your fabulous presentations, and many thanks to participants as well for a very interesting Q&A session. I believe today's session and discussion have provided us much more clarity in terms of the need of these services, implementation, and expected impact of these guidelines in our respective settings. For all of us, the key take-home messages can be around that school eye health is more than vision screening. We need to see that how we make sure that healthy food, clean water, and outdoor activities are part of when we are planning these services in our respective programs. We also need to make sure that teachers and all relevant cadres in our respective settings are part of the process, because they are the one who eventually will take the ownership of whatever has been developed as part of the school eye health or school health programs. Making sure that these programs are inclusive in all different terms, so children with disabilities, how to reach them, how to prioritize them are part of the process. Gender responsiveness of these programs need to be very critical. We all know, we have evidence that girls are the most vulnerable group when it comes to reaching out to eye health services. So we need to make sure that all those relevant strategies are in place. And at the same time, the importance of M&E data cannot be undermined. It's very critical, not only for planning and implementation, but we also need to make sure that it's an ongoing process. So periodically we sit and we review the data, and then we adapt or modify our strategies accordingly. We also need to see that how these guidelines can be adapted in our local context. Priya mentioned it's a living document. The author will update it periodically, but we also need to see that what is most feasible within our local context and how we can adapt it. But at the same time, I believe that these guidelines give us an opportunity to advocate to policymakers for the implementation, adaptation of the minimum standards which they can incorporate in their health and education policies, and then to bring a policy and systems change within the process. At the end, I would like to share that we will be presenting these guidelines to our National Committee of Eye Health in Pakistan in the first week of next month. And the National Committee consists of all key stakeholders from government sector, health and education. At the same time, all INGOs and national NGOs are part of the process as well. So we'll get these endorsed, and then after the endorsement for National Eye Health Committee, we will be launching it, and our Federal Minister of Health has agreed to launch it formally in the last week of December. And by engaging the Federal Minister Office and National Eye Health Committee and the chairman of National Eye Health Committee, we made sure that whoever is working in this particular sphere, they see what these guidelines can provide, and then they take that on board within their program and take that forward. So thank you very much once again to all the presenters and Susan and Emma for your effort and for your time.
Thank you, Samrana. That was an excellent summary of all the discussions that we've had today. And great to hear that you're launching the guidelines in Pakistan, and do let us know how that goes, because I think that might be quite a nice model that could be replicated in different countries as well, that we're trying to, as we try and sort of spread out and disseminate these guidelines. So thank you so much.
For sure, I'll be posting about it a lot. Thank you.
Please.
Sorry, can I just quickly add one last thing?
Please do.
The World Health Organization have got a division at WHO which is all on school eye health, and their recent document talks about how eyes should be included. So that's also a very important advocacy tool to go alongside and say, look, this is what WHO recommends. Thank you.
Oh, great. And maybe we could send a link round to that document as well, actually.
Thanks.
That would be useful as well. Yeah. Okay, great. So I'd like to end now by thanking our presenters, Priya, Claire, Hassan and Samrana, for their comprehensive presentations and thorough responses to all questions. And thank you to IAPB and specifically Emma for giving the School Eye Health Working Group this opportunity to share the guidelines with you all, and also for the technical support. And thank you to everyone who's participated. We really appreciate you taking the time to be part of the IAPB Learn community. And this has been an introduction to the IAPB School Eye Health Guidelines. And if you would like more information, the guidelines themselves are on the IAPB website. So do use them. And as Samrana said, please give us feedback so the guidelines can be constantly improved. And you will now receive a survey via email directly from GoToMeeting. And if you could just take 5 minutes to complete it, as your support for these webinars makes them possible and your feedback helps us to improve them. And thanks again, and look forward to seeing you at future IAPB Learn webinars. And if you're interested to get on the mailing list for these webinars, please contact Emma Footy, and I know she's put her email address in the chat box as well. So thanks again to all of our presenters and all of our attendees, and hopefully catch up soon.